good morning, everyone. I am a current internal medicine resident, and I thought I'd take some time out and make a video about the QT interval, the cutest interval that we have, and the one that we really care about when we're residents in internal medicine. We're just going to talk about some practical things about the QT interval. I'm going to skip over. I'm going to go over really quickly things that I will assume you already know, and hopefully this is helpful to you guys. These are questions that generally come up when we're on the inpatient wards or on rounds. So everyone knows what the QT interval is. The reason we care about the QT interval is in the area of repolarization, if a depolarization happens here is on top of it, it's on the R on T phenomena, and it can precipitate torsades. That's why we care about. You guys probably already know that. One thing I want to point out is that normal physiology, like normally how we're made and our heart is pretty smart, as the heart rate increases, the QT interval will shorten, which is, if you think about it, a good thing. If you pause and take a think about it, it's a pretty good thing. And as the heart, as you have bradycardia, the QT interval will prolong. This will become important later when we're talking about the management of torsades. One other thing is how to measure the QT interval. The QT interval is measured where that T wave hits the isoelectric line, the TP segment. And so you draw like a theoretical line on the T wave, and wherever that crosses your isoelectric line, which is the TP segment, that's your QT interval. If you have a U wave and the U wave is discrete from the T wave, you measure just the T wave where the T wave ends. You don't measure the U wave in. So if the U wave is discrete or if it's large, you measure the end of T wave. If the U wave is kind of smudged up against the T wave, you measure the QU wave. You measure the QU interval, which is this to all the way here. So you kind of include the U wave if it's big. If it's smushed up against the T wave, you include it, and if it's discrete, you do not include it. Then the QTC varies with heart rate. You guys probably already know all this. There are a bunch of formulas we use because the QT that is calculated from the EKG, the one that's calculated on the strips that we see in the United States on the EKG machine, it's used using Bazetts. Bazett is only accurate between 100 and 60 beats per minute. And Bazett will get it wrong if the heart rate is too fast or too slow. So in that instance, we're going to have to think about it a little bit. But Bazetts is sometimes wrong. I read one paper which said Bazetts is wrong 50% of the time. In the EKG machine, the interpretation is wrong, is off 50% of the time. I'll see if I can find it and share it on the channel at some point. So we have Bazetts, we have Frederica, and then Framingham Hodges are not used as much, but these two are the ones that are most commonly used. So that's just something to keep in mind. That, and how Bazetts works is it overcorrects the QTC for heart rates above 100, and it undercorrects at heart rates less than 60. But it's good in between 60 and 100, and most of our patients are usually in between here. If they're either too fast or too slow, you're going to have to think about it. The one other thing is, if you don't know entirely, if you have like a completely normal EKG, let me see if I can find an EKG. One quick and dirty way to calculate the QT interval, which I use a lot in the hospital, is you take the two R intervals and you drop like a theoretical line in between them. So you take this R interval, this RR, you drop a line, and you see if your T wave is ending before that halfway point. If it's ending before that halfway point, you're generally good. The QTC is less than 500, and you're generally good. You don't really have to think about it, and then you can always read what the EKG machine says, usually up there. So you draw like a theoretical line in the middle, and then if the QT ends before it, so in all these instances it's not, so it's suspicious. So this one, you take this R, you draw a line, and that was not good, but this one, it's good. If your QT should end, your QT or QU should end before this. So that's just something to keep in mind. I will go back to the... So Bazetts, we used to calculate. There's a quick and dirty way to calculate the QTC, or else you really have to use Bazetts, Friedrich, and we're going to talk about another formula later, which is not brought up on Life in the Fast Lane. It's called Bogossian or something. Why do we care about the QT? I tried to find some good literature on this. I couldn't really find that much or something really specific, because I really like specific numbers. But it says that above 500, you have a big risk of torsades. I know this is AI telling us, but I agree with it because I went through a bunch of articles. And then for every 10 milliseconds increase in QTC above 500, the risk of torsades increases by 5 to 7%. I couldn't really find what the absolute risk is. It's probably hard to figure out, but like 5 to 7% is quite a big risk of torsades, considering it's like a polymorphic VTAC and you can die from it. So every 10 milliseconds above 500, the risk of torsades increases about 5 to 7%. And the risk is actually like most pronounced when you're above 500 milliseconds, which is pretty long. 450 for men and 460 for females is the same. Now we're quickly going to just talk about torsades. I will pull up an EKG of torsades. Usually I've found that people... this is polymorphic. Let me find. Do we have an EKG for torsades? Let me see. I think there's an EKG in this video that I liked. Oh, one other thing is the best places to look at the QTC, like the easiest ways to find them, are in lead 2, V5, and V6, kind of these leads out here laterally. And these are the best leads to like spot the QTC in. Now, one thing I really liked about this video, where is it? Let me find it, guys. Is the twisting of the, oh, it was maybe not this video. There's a twisting of the points. It's kind of, there's an interesting way to like, let me just put up a Torsades EKG and I'll show you how to differentiate. Yeah, it's kind of sometimes hard for us to differentiate, hey, is this Torsades or is this something else? So one thing I would point out that is in Torsades, you have these points here, and now you have points here, and you have points now down here. And these are all rounded out. And they're rounded out here, and they're rounded out here. So these are the Torsades. So the points, so the EKG is pointy on one end, and then it like flips. So just look at the pointiness, because sometimes with polymorphic VTAC, it's hard to tell if this is polymorphic VTAC or is this Torsades. But in polymorphic VTAC, like Torsades obviously is a type of it. Let me see if there's any other EKG which shows polymorphic VTAC. Let me see if I can find them. But you won't see like the points, you know, the points moving around. This is also Torsades, this is also Torsades. Let me just get rid of this and go up on Google and see if we can find some images. Yeah, so this is polymorphic VTAC. You'll see that there's no twisting of the points. So it's pointy, 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 rounded, 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 pointy, pointy, pointy. There's no real flipping of the points. That's how you kind of tell something is Torsades and the other thing is not Torsades. Well, like obviously twisting the points, you'll see it, but also like the pointiness is, I think, a key, the key feature. Okay, so we talked about QTC, we talked about why we care about it, the risk. It's quite a bit of a risk, even though it's the risk of Torsades, so it's not Torsades, like it's a 5%, 7%, increasing the risk of Torsades, not Torsades itself. Okay. How do you manage Torsades? Well, like everyone will know that you give some mag. I would say the easiest way to memorize is you want to shoot for a supratherapeutic mag of 3.5 to 5. So there's this algorithm here about how you should do. You have to give the mag, you give 4 grams of mag is a reasonable place to start, and then do not stop. Like put them on a mag infusion. Like the big reason that Torsade recurs and you go into this thing called Torsade storm is you give the mag and you don't keep them on some mag. So give them 4 grams of mag or 2 grams of mag or whatever right off the bat, and then put them on 1 gram of mag per hour. I think 1 gram of mag per hour. So load them with 4 grams in 1 hour and start a gram an hour, and then keep checking that mag. The reason is that like if you overdo the mag, you'll have like hypermagnesemia symptoms, which is respiratory depression, delayed deep tendon reflexes, bradycardia, whatever, all that stuff. So 4 grams of mag and then 1 gram of mag an hour. So you do a mag infusion, and then if their EGFR is low and they're end-stage renal disease, you just bolus the mag and you keep checking the mag level, and you keep the mag super therapeutic, 3.5 to 5. And then magnesium is a good drug. I really like mag for everything. So load them with mag. If the target mag is this, if mag is 5.7, these guys recommend just copying and pasting this into the chart. So keep the mag between like 3.5 and 5. If the mag is really high, reduce the infusion rate. So if they're on 1 gram an hour, put it at 0.5 grams an hour. If it's greater than 7, stop, and then just reevaluate. The one thing I would point out is treat hypokalemia, hypocalcemia, and hypothermia aggressively. These also will be causes of prolonged QTC. We'll talk about that in a bit. And then one thing I'd say about hypocalcemia is if they have cirrhosis and their liver is all messed up, calcium gluconate, which is the calcium that we give in the hospital, is metabolized by the liver into like actual calcium, and that's how it does. But if their liver is all messed up, if they're cirrhotic, give calcium chloride. Calcium chloride does not have to undergo metabolism by the liver and to work, so you can give calcium chloride, don't give calcium gluconate. That's just another thing. So we now know that we're going to give mag, stuff like this. Now, one other thing that I would think is that if they're going into recurrent Torsade, they went into Torsade, then you give them some mag, and then they're back into it. This is usually because you did not give enough mag or they're not on a mag infusion. One other thing is, remember how we talked about when you speed up, like, well, you want to shorten the QTC. That's why you're doing all of this. The one thing that you can do is we talked about earlier that you can speed up the heart, and speeding up the heart decreases the QTC because that's just how the body is made. You can speed up the heart. So how can you speed up the heart? You can give chronotropy. You can speed them up. How can you speed them up? If they're hypotensive, epinephrine, but I would say like this is one of those cool instances in medicine where epi is not the first line choice. You can use dobutamine or isoproterenol. Isoproterenol, if you remember, is a pure beta-1, beta-2 agonist. So it will just speed them up. Just speed them up. That's kind of so give mag. If it's still a problem, either give epi for some beta, like speed up that heart rate. Target 140 or 110 to 100 to 110, and speed them up. This is one of those few instances where isoproterenol or dobutamine is the pressor of choice and nothing else. And then if they're still going into torsades, you can always do lidocaine. Lidocaine is preferred because lidocaine does not prolong the QTC. Beta blockers will slow down the heart rate and prolong the QTC. So this is the loading doses, 1 to 1.5 mg per kg, right? Followed by an infusion. At this point, obviously, cardiology is involved and things like that. But it's just always good to know like what your options are. So your options are MAG, speeding them up, and lidocaine. And then if all of this is not doing it, the Internet Book of Critical Care, which is what I really like, it says that it should be fairly easy to control. If it's not being controlled on this, like think of other causes. So we talked about torsades. Now let's talk about, let's see, what else do I want to talk about? One other thing I want to talk about that came up in this video that I really liked is what to do in settings of paced rhythms. In paced rhythms where the QRS is already wide, the QT interval will obviously increase because the QRS is wide. Use this other formula called the Bogossian formula. I will touch on this in the end, but the Bogossian formula is, you know Bazetts, you know Friedricha, and now you know Bogossian formula for paced rhythms, for left bundle, and even for right bundle. There's some good literature out there that right bundle helps as well. Thank you to the people at Cardio Nerds for this video. It's a really good video. You guys should watch it. The one other thing that I want to talk about, I talked about everything from here. So one other clinical pearl I want to talk about is usually antiemetics in the hospital. Most of them will prolong the QTC. The ones that we use most commonly are ondansetron. So that will usually prolong the QTC. So you kind of run into a problem. Granisetron doesn't prolong the QTC as much. But it's super expensive. So ondansetron is a no-go, metoclopramide is a no-go, diphenhydramine is a no-go, promethazine is a no-go, metoclopramide, all that stuff that we give, Reglan, Compazine, this, that, whatever is a no-go. All of these will prolong the QTC. So I find like interns always struggle with, oh, someone is nauseous, what do I do? QTC is 512. So things that you can use. Benzodiazepines, believe it or not, have a pretty good antiemetic effect. So you can give a little bit of a benzo, but obviously be cautious. You can give scopolamine. You could put it on PO. You can put it on a patch. You can do quite a bit of stuff with scopolamine. So slap a scopolamine patch on them. You can use this phosphate, all this type of stuff, these neurokinin receptor antagonists. And then dexamethasone as well has quite a good of like antiemetic activity. They give it like, you'll see them on the chemo regimens where they're getting dexamethasone. So these are kind of the ones that we have. So you can do scopolamine, benzo, dexamethasone, this fosaprepirin, and then the last one I would add to this is olanzapine. They haven't written it here, but olanzapine doesn't prolong the QTC at all. So we think of an antipsychotic dose, this, that, whatever, but if you pull it up on UpToDate, you'll have an antiemetic dose there. So you could give some Zyprexa, which is olanzapine. This is another thing just showing, this is from UpToDate. Obviously, you guys already know that. So scopolamine is a transdermal patch. It does not prolong the QTC. You can use granisetron. It does not really prolong the QTC, I would say. Oh, or palosetron is the one, actually. I forgot. Yeah, palosetron is the one. It's exorbitantly expensive, though, so it's kind of difficult to use. Olanzapine, remember that. Diphenhydramine, all this stuff will prolong QTC. Dexamethasone will not. And then ondansetron will, obviously. So that's kind of about that. Now, prolonged QTC, I want to talk about the differential of prolonged QTC is obviously like electrolyte issues, hypocalcemia, hypomagnesemia, hypokalemia. Hypothermia will prolong it. Elevated ICP will prolong it. A lot of meds will prolong it. You guys probably already know that. There can be congenital causes. So one thing I wanted to point it out, I'll talk about this right now. So with one interesting thing is with hypocalcemia, the way hypocalcemia prolongs the QTC, you could have two options. One option is you have this, and the QTC is prolonged because like the entire T wave is just super big. And one option is this hypocalcemia that they've shown, where the ST segment is long and the T wave just comes in normally, but it comes in late. So overall, this QTC is long, but it's long mostly because the ST segment is long. This is pretty specific for hypocalcemia. If you ever see this, where the ST segment is long and then the T wave is normal, and the QTC overall will be prolonged, it's probably hypocalcemia. So what I'm trying to get at is there's a different differential for this and this. These are both prolonged QTC, but this is different than this, and this generally is hypocalcemia. That's just one thing I wanted to point out. And then here is the differential, I think, for short QTC. For short QTC is hypercalcemia. Hypercalcemia has like, usually the QTC will short. Usually it smushes the T wave into the QRS. And then hypercalcemia is a big mimicker of STEMI as well. Because like you could imagine that if you're seeing, or if it gets really smushed, and this will, imagine this is a QRS. As this gets really smushed into the QRS, if the T wave gets really smushed into the QRS, it's a big mimicker of STEMI. And then DIG, and then congenital short QTC syndrome. All right. Oh, I was trying to look on Twitter if I could see something any good. But this is that correction, the Bogossian formula. The Bogossian formula will correct for the QTC in the setting of a paste rhythm, the setting of a bundle branch block. So you could use this. It's not on MD Calc, unfortunately. You will have to kind of do it yourself. But the Bogossian formula is the thing. And then I think this is not the original paper, but there's a bunch of papers like validating this, the Bogossian formula for evaluation of QT in a paste rhythm of a left bundle. And then the last thing I really wanted to talk about really quickly was, in the setting of AFib becomes difficult, in the setting of fast heart rate it becomes difficult. So you're gonna have to think about it. But like in my practice, if I do I drop a line between the two RR intervals, if the QTC is over it, and then the machine is reading it as fast, now I have to stop and think about it and see what I can do about it. And usually if you stop any offending medications or things like that, like it comes down rather nicely. So that's everything I have for you. I hope you guys learned something, and I will see you guys in the next one.